Welcome to ETSU Department of Psychiatry's Grand Rounds. Dr. Clements is lecturing us today. She's a professor of psychology and assistant chair here at ETSU, specializing in child psychological science concentration coordinator. She got her bachelor's of science in interdisciplinary counseling at the University of Alabama, got her master's in rehabilitation counseling at the University of Alabama with concentrations in rehabilitation and mental health counseling. And she got her Ph.D. in educational psychology at the University of Alabama as well. Concentrations in industrial and organizational psychology, statistics, and rehabilitation counseling. She did her dissertation on the incidence of ADHD in children whose mothers experienced extreme psychological stress during pregnancy. Dr. Clements?
Same. Okay. Yes, I am a psychology professor here, and I'm not even sure why I was asked to present today, but that's okay, because I'm going to tell you something that I'm passionately working on right now. And I'm going to say we several times, because a lot of times when I present on this topic, I present with Becky Haas from the police department here in town. And what we have been doing is trying to develop a trauma-informed care system in our area with lots of different organizations. And so we have taught on trauma-informed care in school personnel, with I'm trying to think where all we've done, Boys and Girls Clubs, with agencies that work with homeless individuals. We've gone to Knoxville and taught several agencies there and so forth, to try to sort of disseminate some information at the ground level for a broad audience in trauma-informed care, which if you're not familiar with, I will define really well by the end of this, and also talk about the ACE study, the Adverse Childhood Experiences study, which I will also talk about. And what we do when we do trainings for organizations is we typically do about a 4.5-hour training. This is an hour training, so it's going to be fast and furious, and I will skip a lot of things that I'm sure you're already quite aware of because of the audience that you are. But I want you to see sort of the flavor of what we're teaching people. And so there are several embedded videos, and I started to leave some of them out, but some of them have been the most, I guess, meaningful parts of the trainings that we've done. So I figure in order to keep the flavor of what we're doing, it would be best to keep those in. So I'll talk some, and then I'll pepper it with videos, and you are welcome to ask questions as you have them. My mandatory disclosure statements. We've been doing this for free for months and using lots of time, so I am not making any money on this, and I don't have any investigative equipment. All right, so understanding trauma, which is hilarious for me to be teaching a psychiatry audience about trauma. So I'm going to run through highlights of what we do, but not in as much depth, because oftentimes we're talking to people that don't have training in psychology or psychiatry. But one of the things that I want to emphasize is that there are several organizations, several groups, and lots of other people who have just done some reading that are teaching about trauma-informed care, adverse childhood experiences, and so forth. What we have done is developed a training based on the National Center for Trauma-Informed Care, I guess, view of trauma-informed care. And if some of you, did any of you attend the training last October that was over at the Culp Center? Okay, one, that's great. That was representatives from the National Center for Trauma-Informed Care, or NCTIC, that came and presented here. And then they sort of blessed us as trainers, sent us their materials, and we have adapted them to various audiences and are staying in touch with them. So if it sounds a little different from something you've heard, it may be because it was from some other organization. But theirs is the SAMHSA funded, on the SAMHSA site, their take on trauma-informed care. And so I just want to give you some highlights. What we're talking about is refocusing lots of perspectives from not what's wrong with you, what's your diagnosis or whatever, but what happened in your past that might be contributing to what's going on now. Looking at symptoms as adaptations to trauma rather than evidence of some disease or disorder, and then promoting the idea that healing happens in kind, empathetic relationships. And we focus on empathy, not sympathy. And this next, I'm going to show, this is a really short video, but I want to kind of set it up by saying that what we're trying to do is promote actually being in it with people, I guess. And I know in paid helping professions such as psychiatry, psychology, oftentimes there's this element of, ooh, we can't get too close, we can't get too involved, and that's going to be a tension when you are in that profession, and I realize that. A lot of people that we're training are people that are teachers or bus drivers or lunch ladies or whatever, and so there's a little bit of difference in the profession there. So, but I'm going to hopefully, nope, figure out how to do this. There we go.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Trying to teach on-the-ground people who are interacting with whoever is coming through the door or with each other. So this can be a staff-to-staff thing. It can be a office lady to a student thing. It could be a receptionist to a patient. But we're trying to infuse this idea of empathizing and interacting with people in a compassionate, empathic way wherever they meet them. So quite common here, perspective taking, you understand that. Not being judgmental, you understand that. Recognizing others' emotions, communicating recognition, and so forth. Less encouraged, I'm sure, if you are in a therapeutic role, is that getting down in the trenches and feeling the pain and hugs and so forth and so on. And I understand that, but this is one of the things that we're teaching in our regular trainings. And so professionally, think through that, I guess, because I know I used to be you heard my degrees, I used to be a a mental health counselor years and years and years and years and years ago. And there was that, don't be too close, maintain your professional boundaries and things like that. And yes, we have to have boundaries, but I guess it doesn't keep us from empathizing to an extent. I'm going to go on because I have lots of things. One of the things that right now, and I'll get in a little while to talk about some of the research being done in this field, but one of the stories that is a good example of this occurring in a school, and this is an implementation of trauma-informed care in a school that decided to take this on, was an alternative school in Walla Walla, Washington. And what they did is they had a ridiculously high recidivism. No, we're not doing crime yet. Suspensions. They had high suspension rate, low graduation rate, and it was just an out-of-control school. And they decided they would go out on a limb and do something extreme. And so what they decided to do was change the philosophy of the school, and they adopted the trauma-informed care model. And the only thing that they really changed, other than training their staff in the empathy and compassion kind of idea, was they set up, instead of having the in-school suspension room be a harsh, bright light, sit down there and do your work, you're in trouble sort of room, they changed it to couches, warm lighting, and a compassionate person there to greet people when they came in, as opposed to, you're going under the bus. It was more of a, what happened? Can you tell me how your day was? And so forth. And so what they saw happen in 1 year was suspensions went from 798 to 135, and graduations went from 9 to 60. So probably a lot of what was going on is these kids were in these dire circumstances, and so having someone actually listen and just hear them out and not immediately blame them or shame them apparently did something. Again, there's research starting. All right, so from this training model, there are 3 things that we look at. We look at, defining trauma. We look at, they call it the 3 E's. There's an event that is experienced and has some sort of effect. And so and I'll talk more a little bit about that because I'll run out of time without all of my fantastic information. Potential traumatic events. It could be some type of abuse, chronic stressors, losses, all kinds of things could be traumatic to a person depending on how they perceive that, how they experience it. And so the same thing might be experienced by multiple people. Some of them experience it as very traumatic and have lasting effects. Some people don't even realize it was supposed to be a traumatic event. So obviously that's going to be an individual difference. Some of the experience that the people feel is going to hinge on who perpetrated, who did it. If it's a child and it's a trusted caregiver, that's going to be very different than if it's a one-time event by a stranger you never have to see again. When it was, how old you were, where it happened. Is it in your house, or was it somewhere that you were visiting on a vacation, or is it where you have to walk down the street every day? How often did it occur? So is it a one-time thing, or is it just going on and on and on and on? And all of those things can increase or decrease the extent to which this will actually affect the individual. And then the effects of trauma. If you think about it, any of us that experience something stressful, there's a normal response. We have, endocrine responses. We have, heart rate goes up, whatever. And so anytime that we react to stress, that's okay. It's normal. It's when it becomes chronic and ongoing and you're always on high alert that it can be more damaging. And some of the things we see are physical disease, substance abuse, and mental illness. And substance abuse is one of my, I won't even say sideline, one of my other mainline things that I am trying to address right now. But one of the things that this focuses on, this particular training, and particularly, as you heard, even from my dissertation, 20-something years ago, 25 years ago, 26, however long ago that was, it was a long time ago, was on prenatal stress and the effects of that. So we've known for a long time that early stressors, either prenatally or in childhood and so forth, can have these ongoing bad effects and so forth. And I've got a couple of short videos that sum that up better than I can say.
Science tells us that the experiences we have in the first years of our lives actually affect the physical architecture of the developing brain. This means that brains aren't just born, they're also built over time based on our experiences. Just as a house needs a sturdy foundation to support the walls and roof, a brain needs a good base to support all future development. Positive interactions between young children and their caregivers literally build the architecture of the developing brain. Building a sturdy foundation in the early years provides a good basis for a lifetime of good mental function and better overall health. So just how is a solid brain foundation built and maintained in a developing child? One way is through what brain experts call serve and return interactions. Imagine a tennis match between a caregiver and a child, but instead of hitting a ball back and forth across a net, various forms of communication pass between the two. From eye contact to touch, from singing to simple games like peekaboo. These interactions, repeated throughout a young person's developing years, are the bricks that build a healthy foundation for all future development. But another kind of childhood experience shapes brain development too, and that's stress. Good kinds of stress, like meeting new people or studying for a test, are healthy for development because they prepare kids to cope with future challenges. Another kind of stress, called toxic stress, is bad for brain development. If a child is exposed to serious, ongoing hardships like abuse and neglect, and he has no other caregiver in his life to provide support, the basic structures of his developing brain may be damaged. Without a sturdy foundation to properly support future development, he is at risk for a lifetime of health problems, development issues, even addiction. It's possible to fix some of the damage of toxic stress later on, but it's easier, more effective, and less expensive to build solid brain architecture in the first place. One of the things that sturdy brain architecture supports is the development of basic emotional and social skills, an important group of skills which scientists call executive function and self-regulation can be thought of like air traffic control in the child's mental airspace. Think of a young child's brain as the control tower at a busy airport. All those planes landing and taking off and all of the support systems on the ground simultaneously demand the controller's attention to avoid a crash. It's the same with a young child learning to pay attention, plan ahead and remember, and follow lots of rules. Like all of us, kids have to react to things happening in the world around them, while also dealing with worries, temptations, and obligations on their minds. As these demands for attention pile up, air traffic control helps a child regulate the flow of information, prioritize tasks, and above all, find ways to manage stress and avoid mental collisions along the way. Having this ability is a necessity for positive and level mental health. Developing effective air traffic control, overcoming toxic stress, and building solid brain architecture are things kids can't do on their own. And since strong societies are made up of healthy, contributing individuals, it's up to us as a community to make sure all young people have the kinds of nurturing experiences they need for positive development. To build better futures, we need to build better brains.
Similar videos that are put out by the Center on the Developing Child at Harvard that give some brief overviews of brain development and show some examples of caregiver-child interaction. It doesn't have to be parent-child, but caregiver-child interaction and the serve and return interaction that is helpful to offset or maybe prevent some of the effects of toxic stress. So some of the factors that increase the impact of toxic stress or early trauma, kind of use those interchangeably. Early occurrence, being blamed or shamed or even just not listened to about what's going on, silenced or not believed, or having the perpetrator be a trusted caregiver. Say perpetrator sounds very legal, but whoever is the root of that's going on. And so we want to know how we can offset the effects of that. And so we know that, just like in this video, children children are less able to cope with stressors than adults are. And so what happens early on is that parents or caregivers or teachers or whoever, the lady in the in-school suspension room or the man in the in-school suspension room, can help calm the person externally, the child externally, until they gain that capacity to calm themselves. And so if there's not somebody to calm the child down, then you've got this constant state of sort of high alert. And so that's what we're trying to promote. And the thing is, and I know I'm speaking to a fairly professional body now, fairly, that's a bad thing, a professional body now, but most of the time these kids aren't getting to you until something's already broken. So that's why we're so interested in training the on-the-ground folks that are seeing these kids all the time, because we're trying to cut your patient load. That's what we're trying to do. So, okay, and I don't know, how many of you are familiar already with the ACE study? Probably all of you pretty well, okay. In case nobody is, I'm going to show you this short video. It's a really short video, but it really sums it up so quickly. And it works when you download it into your PowerPoint and not so much online. So it's downloaded, don't worry.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
Okay, so I think most audiences now believe, yeah, okay, the early childhood adversity does predict later health things. And I redid a lit review probably about a month ago before we did a training to see how many studies were out there, and many keep verifying, yep, it's a health risk, yep, it's a health risk. And I am the person that says, yeah, but what do we do about it? So this is where I am now. So the research community is convinced that there is a connection. It hasn't been causal research. Obviously, we're not going around, randomly assigning people to have adverse childhood experiences. We can't do that. But there's a lot of evidence that it is at least predictive. And I am one of those people that would rather move on from verifying how it's causing to, well, is there something that we can fix that will prevent it, and then we don't have to care how it was caused. So diagnosis is great. Treatment or cure is better. And the research is really just starting. In a minute, I'll tell you about some that I am doing. But I wanted to just share with you, Becky and I both taught this at the Tough Pill to Swallow last month, I guess, when that MCE event was. And so I put together some of the current recommendations. So American Academy of Pediatrics, addressing adverse childhood experiences. And it doesn't just say measure. It does say measure. Why are we looking? What are we looking for? How do we find it? But then what do we do? And it gives some suggestions for steps to take now while the research is accumulating. And some of the ideas, there are several ideas given, looking at parents' experiences, not just the child's. In fact, I was at a meeting yesterday. I'll go ahead and tell you some of the research that's going on is going to be some of mine, because there have been very few empirical studies to look at ways to reduce ACEs and then ways to reduce effects of ACEs. And so I just got a grant from the state to do a demonstration project at the Boys and Girls Club here. And so I had to go to a meeting in Nashville yesterday where all the people who received those grants got together, and we were all sharing what is my project, what is your project, what is my project, what is your project. And there are several, including ours, empirical studies that are actually looking at, let's do the trauma-informed perspective and measure with and without and compare to comparison sites, and train some parents and compare behavior of parents and children who were trained about ACEs and not trained about ACEs and so forth. So hopefully that's going on lots of places. It definitely is going on in Tennessee. So I expect in the next 3 or 4 years that there will actually be some empirical evidence for, have we found a way to both reduce the number of ACEs and hopefully reduce the effects of those ACEs in kids. It'd be great if we could just get rid of the ACEs. That would be best, but some people have already experienced them, so that's another thing. Also, there's a couple of other articles that are listed, and then one thing that the originators of the, Dr. Felitti, who was co-creator of the original ACE study, did another follow-up study, and one of the things that people have been skeptical of, if you're just talking to them, what do you do then? It's like, you're just basically acknowledging trauma may have happened and I'm willing to listen. You're not a particular protocol to follow. And this is what they did with 120 records of 125,000 those who actually were administered the ACE test, which is just those 10 questions, did it ever happen, doesn't ask how many times, just did it ever happen, and then were asked about that, had a 35% reduction in doctor visits, 11% reduction in emergency room visits. Is it directly causal? Probably not, but there may be something to that. If you have a huge reduction, something is going on. So that's why I say we need more controlled studies so that we do know what is being effective and what effect that's having. But the thing that we keep preaching, for lack of a better term, is that the empathy itself may be therapeutic without having to have a treatment protocol, just being empathic. This is a few other studies. I got real excited when I saw some of these because we've got this intervention, and everyone I looked up was like, we have started it, and we will report on results. So they're all happening, but the results are not in yet. Okay, there has been some reluctance on the part of particularly non-professional psychologists, psychiatrists, and counselors, and so forth, to open the can of worms. Well, if I ask about it, I'll find something out, then I'll have to deal with it, then what do? I'll have to refer, and so forth. And one of the things that's interesting about this is in the original study, that same worry was there. And so the IRB that approved the study said you have to have a counselor on call 24/7 during the entire study. 0 calls. No one ever called. 17,000 people. Who has a subject, that size subject pool, and nobody ever called. But we also had that concern. We started talking to some of the agencies here before we began training, and they said, what do we do if we need to refer? So we asked the National Center for Trauma-Informed Care. We said, hey, could we train some therapists in the area so that if the can of worms is open and we need some referrals, we know there's some people that are trained in trauma-informed care and so forth. And so they sent a trainer, and we did 2 days of training in April. And trained 60 therapists in the area, master's level and above therapists in the area, and I think there were 12 from the school system. There were several from Frontier Health, lots of different agencies. So there are a lot, and I know that I had talked to Michelle Mosier recently, and she said that the folks that work with children have known about this since 2008. Where was I? I don't know. I was doing something else. But so there are a lot of folks in the area, as far as trained therapists goes, who are very familiar with us and able to take people on if indeed they do need referral. So that is, I don't think that's a worry anymore. We have those, but so far, again, we haven't had, as we've approached this, we've administered the ACE test in various areas. We've talked about your history of trauma and so forth. We haven't had anybody melt down. They know they had it. They know they lived through it. It's just finally it's okay to talk about. All right, so some assumptions and aims in general. That their ACEs and health problems, yeah, we know that those are related, predictive at least. We always will want to reduce childhood trauma. Nobody wants to keep it where it is or raise it. That just doesn't make sense. So we all want to reduce that. We hope that some of these interventions will improve the health and will reduce substance abuse. That is the huge goal. And then those reductions will reduce health problems in general, healthcare costs, crime, improve quality of life. It's like the magic pill, hopefully. And so, well, I'll tell you a bit about what we're teaching as far as trauma-informed care, and then I'm going to tell you a little bit about the project we're going to do that we're working on now. So it doesn't even have a good name. It's a strategy, a mindset, an approach, a paradigm. I don't even know what to call it. It's a thing. But basically what we're promoting is that you're aware of psychological and emotional needs as well as physical needs. So focusing on somebody in wherever they are, in their place. Coming from a perspective of empathy, not blame. And one of the things that I talk to and volunteer actually with and do assessment with, some offender programs. And I think talking to you, this is not such a big thing, but talking to probation, parole, jail employees and so forth, switching from blame or punishment to empathy is a big swing, and that's been one of our tougher nuts to crack. Treat everyone with respect as equal valued human beings. And I think if we just left and did that with the people that we work with, I mean, like our co-employees, our peers and our jobs and our bosses and our employees and our patients and everybody else, if we just did that one, I think we'd all be good to go. but it has to be intentional, I think. Acknowledge trauma and encourage open discussion to the extent the person wants to be open. And that's one of the things. It's like, oh, you must talk about your trauma or you won't get better. And I don't know that that's true. The fellow that came and did the training for our therapist said that he actually works in a prison, and a women's prison, and runs trauma-informed groups with these women, and most of them have hugely high ACE scores. And he said he had one particular person that I forget how long, it's like a 10-week session of TIC groups or whatever that they do. And he had one person that came to everyone, every time they were there, never spoke a word, just sat there. And you're not required to, it's like to the extent that you want to, the entire time. And they said their goodbyes at the last session. This is, great having you, call me if you need me, whatever. And the person came up and said that was the most meaningful thing they had ever experienced. Never spoke a word, but it was just that, they were accepted, other people shared and so forth, but it was just being there and knowing it was okay to, even though they didn't share necessarily. So acknowledging it and realizing that could be something that has contributed to what's going on with them now. All right, so trauma-informed services, as we teach this, that we know that violence, victimization, whatever the adverse childhood experiences they've had, and we say childhood, but even as an adult, you can still have trauma going on. So even if it didn't happen before you're 18, maybe it happened when you're 19, that affects things beyond that. But in our places where we are seeing people, treating people, meeting people, whatever, try to think in terms of, are there things going on that might re-traumatize somebody? Some of the things we have talked about with, we were talking with, as they were setting up the Family Justice Center downtown that just opened. They met with some of these women who are obviously experiencing abuse. That's why there's a Family Justice Center. And talked with them about what would make you most comfortable, what would make you uncomfortable. And it was things like that you would never think of, but it was, I don't mind being where my kids can't, I don't mind if I'm somewhere where they can't hear what I'm saying, but I want to be able to see them the whole time because there's this threat of somebody taking their children. And so they have glass between, so the mom can see the kids all the time she's there, can't hear what's going on, but she's always got her eyes on them. I don't want to be in a room with only one exit and my back is toward it, because I can't get away. Those kind of things, and you wouldn't, if you haven't been there, you might not think of that, but whatever your location is, try to think of ways that, think of potential for re-traumatization and re-victimization and try to avoid those. Respectful of a person's choices and control over their treatment. Now that is one thing that when we get into the medical field, most people in medical fields are pretty revered by people who don't have medical education. It's like, well, whatever you say, you probably know what's best. And trauma-informed care very much promotes letting people be grown-ups who make their own decisions. I don't want to be treated. That's your decision. You're a grown-up. You don't have to be treated. Or I do want to be treated. Or I don't want that treatment. I want this treatment. Or I don't want that therapist. I want this therapist. Whatever. And I know there are constraints there, just from insurance and staffing and things like that. But understand that people are valuable, autonomous beings who can make decisions for themselves, and not try to guilt somebody into something or whatever, but to let them have as many choices as they can in the situation that they're in. Being more a partner on the same level. One of the things that trauma-informed care is very central, the way it's taught by NICTIC, is getting rid of power differentials so that it's not me over you. I mean, even when it's teacher to child, yes, the teacher is going to control an environment. The teacher's got to keep the peace. The teacher is in control and can do things that the child cannot, but not to abuse that or leverage it so much, but to even if it's get down on the child's level to talk, or to not force them just because you can, but to try to balance that power differential. Okay, the goal is to facilitate recovery, growth, resilience, healing. Yes, I think that's all of ours. Using non-traditional collaborations, faith communities, friends, family, whoever, not just other health professionals. Emphasizing strengths rather than deficits, not, oh, you have this symptom and this symptom and this symptom, and so we've got to treat those, but more, you know, what do you bring to the situation? What can we capitalize on? What have you got going for? I mean, I'll give you a good example. The corrections program that I work with, there was the nicest, most jovial drug dealer there. Great drug dealer. He's good at what he does. But he's now graduated and he's doing great. But he is a salesman. That's what he does. And so it's like, okay, you did that really well. Let's try it with something legal. You know, so now he's into some endeavors that are legal, public, good, you know, and he's using those skills, but instead of saying, oh, can't let you do that, just leave that behind you. Well, leave the illegal parts behind you, but heck, heck, you can sell anything to anybody. So, and get away with it for a long time. But, so anyway, also being culturally sensitive and focusing on trust and safety, because most people that have been victimized somewhere along the way have trust issues, have some safety issues. They're vulnerable. All right, so I want to tell you briefly, okay, oh good, my watch is fast. Briefly about what we're doing, the Boys and Girls Club. What we're going to do is teach the parents about ACEs, and some of the group of the parents about ACEs and about serve and return interaction with their children very specifically. So we're giving them tools. It's like, you might not have known that this could be damaging to your child's brain development. This could be responsible for some of the learning difficulties or the behavior difficulties or whatever, and we want to help you to be good for your child and show you some tools that you can use and actually give them tools that they can use and see if that does change the way they interact with their kids. Because many of these moms and caregivers, guardians, grandparents, whoever's taking care of the child, have not learned that anywhere. You know, if they didn't experience it, where were they going to learn it? And so instead of saying, oh, you should do this better, it's like, we don't care that you didn't know how to do it better. Let's see if we can do it better. We've got this new research. We want you to know about it. So even that expresses some value, because these are not the people you generally run to and say, oh, hey, there's some new research findings. But I think they would speak to them. Every parent wants what's best for their kid. They may not be good at getting it, but they want what's best for their kid. So, so that, and then we're going to train all of the staff and volunteers at the Boys and Girls Club here in town in trauma-informed principles, the empathy and the value and the capitalizing on strengths and so forth. And we'll have somebody there at the center that will be doing ongoing training and also monitoring and correcting and so forth, so that making sure that it really is happening there. And then we're going to compare to some other Boys and Girls Clubs that have had just the brief training but don't have it like infused and a paid person to watch you or work with you. And so we're going to compare to some sister sites, and then we're going to compare to national data. And I think we will see some changes. I think we will in attendance and hopefully in achievement kinds of things. And then with the parents, guardians, we're going to have a control group that does get a training, but it's not an ACE-focused, TIC-focused thing. It's going to be on like education and jobs after school or something like that. But they still, same amount of time, so just as a control, and work with those parents. And then we're going to have some parents that don't attend trainings at all. And we're actually going to do follow-up observations of parents interacting with their kids. And I don't know about the group, the control group that we actually meet with, but I think the ones that see the ACE stuff and get those skills, I think we will see some differences. I won't be watching, don't worry, I know I'm biased. I have other people that are going to do that. So I won't even be there. I'm just telling them what to go do. So, but hopefully, then we'll have some actual research to build on. And and it should be very simple and exportable, so then we can use it with other agencies and so forth. This last thing that I want to do is, I have this video, and I thought about not showing it, but I'm going to because, and I am absolutely on time, because of everything, every time we do one of these trainings, it's this video that speaks to people, you know, not everybody, but it's an example of just kind of day in the life of a child in a traumatic situation. And so what I want you to do as you watch this, and then we'll talk for a minute afterwards, it's about 12 minutes long, but it is actors. It's a true story written by the person who lived it, but it's actually actors, but the actors are so good you'll believe it's them. So I want you to watch for evidence of kind of the things that I've talked about as trauma-informed, and maybe things that are not so trauma-informed. So empathy, harshness, lack of control, listening, things like that. And then we'll talk for a minute when it's over. And that will be almost the end.
Sometimes someone hurts you so bad.
I don't think you understand.
It stops hurting at all. Until something makes you feel again. And then it all comes back. Every word, every hurt, every moment. How could you ever understand where I come from? Even if you ask, even if you listen, you do not really hear, see, or feel. You don't remember my story. You haven't walked my path. You haven't seen what I've seen. My past defines me. This is who I am. I am unseen, unheard, unwanted. That is what I am, if even I am anything. It seemed like the same thing that held me up forced me down. The world turned upside down, and order disappeared. Nothing was how it was supposed to be. And a heavy sadness filled my soul. deeper I fell within myself. And nothing could draw me out. Trapped in the misery of my life. Lost in the sorrow of my soul. Unable to see the light. Unable to see the dawn. To feel. To hope.
What are you doing picking my fruit?
To dream. And I found the darkest days of my life kept coming. The blackest nights for my soul never stopped. It seemed like it was always nighttime and nightmares, and never morning. And maybe you wonder why, but mostly you try not to think about it, and try to get by, and try to survive. And all the other stuff seems so much like nothing, compared to just wanting the most important things back again. Like wishing you could see your mama smile again, and hear her sing that one favorite song that always calmed you down when things were all messed up. Or if you couldn't have her back, at least get to take care of your baby brother. 'Cause you know he needs you, and he's gonna be so scared all alone. And who's gonna hold his hand and whisper it'll be all right to him? And who will whisper it to me? I know I am helpless, dependent, desperate. But what happens when those you need the most threaten your very existence? I've heard plenty of promises, and they all sound the same. But push hard enough, and sooner or later, they all prove to be empty. The sun comes up every morning, but do you know where? Each place, it's somewhere different. It's hard to find east when you keep moving around. But at least it comes. It always comes. I've come to depend on that. And slowly seasons changed around me. And it seemed this time that maybe the world would not be pulled out from under me again. Feet safe, roots starting to grow, little buds of hope forming, slowly attempting to trust this new life.
Hi, come on over. Let me show you what I got for you. Got you a gift.
I wish someone would tell me it's gonna be okay.
I come home, I swear to God you touch me again, I will kill you.
Don't touch me! Don't care about me! That one day, maybe, I feel normal. That I won't always be alone. I'll have a mommy who will hug me and be strong for me. Because maybe I can't do it all by myself.
Hi, yes. I'm calling to let you guys know that I have moved from another placement. Thank you so much. Yes. Okay, make sure you know.
This, my past, my history, my story, is not my fault. It's not because of me. And doesn't have to be what defines my future. I am lovable. I am worthy of care. And that glimmer of light, it makes all the difference. The glimmers of light give me hope that someday my summer will come.
Okay, there is a part 2 to that too, if you ever want. It's twice as long. But one of the reasons that we show that, I'm going to do this really quickly instead of asking you all for your ideas, but some of the things that were really vividly portrayed in that 12-minute video are kind of getting in the life of a child and what some kids go through. So many kids in our area go through this all the time, every day. It's just where they exist. Then the children being split up. I know there are organizations now in town particularly that are working to keep all the kids together, whoever the kids are, however many there are, to keep them together, because that, again, is another loss. You're lost from your parents, but you're also lost from those siblings, and they're lost from each other. The first family where it's like the piece of fruit was so important to the foster mom, I guess it's foster mom, and instead of, cutting her a little slack and letting her have a plum or whatever, but she ends up yelling at her, and the little girl acts out. No, she should not have thrown the stereo over the deck, obviously. It's not an excuse for bad behavior, but it's like, she was so wired up and frustrated anyway, and so then getting hosed down in the shower is not the most loving way to handle that, I don't think. But then the second mom, and I do want to talk about that second woman, because she squatted down, she smiled, she welcomed her, she just let things, tearing up the book, whatever, screeching at her. It's like she was in it for the long haul, and that's what so many of these kids have not had, is somebody that's in it for the long haul, and even once they're adults, maybe have not had that. And so the trauma-informed approach is, I hate to say gives them a break, gives people a break, but it's like you don't immediately go to let's correct it, let's punish, whatever, but let's try to understand it and come to some sort of mutual conclusion instead of immediately blaming the person and being above them and giving them consequences and so forth. So that's one of the reasons that I just wanted to show that to you, because that has been, I think, our trainings would fall flat if we didn't show that video, because it so brings so many of the things together. And I do want to acknowledge Becky Haas is the one who sucked me into this, and so she would be here, except that she's in California sucking other people into it right now. But this is our contact